gonna, the format here is stop me anytime, be critical, I'm an economist, I can take it. It's fine if we get through everything, it's fine if we don't. I've got it's kind of front-loaded with what I would like to cover. Basic ideas, why bother with this sort of exercise, different approaches to doing economic evaluations, decision analysis and cost-effectiveness analysis, and just some explanation of some of the output that you'll see. How do you interpret results from these studies? And some examples to kind of give it some concreteness. The basic idea is that we have to make choices, and we don't always know precisely what the outcomes of those choices are. And we also have to deal with competing objectives. So what decision analysis does is provide us a framework for looking at the sort of choices that we have to make. So uncertainty, we often have diagnostic uncertainty. We're not sure exactly what we're dealing with. When you're evaluating test results, tests are often provide less than perfect information. So we have to deal with the fact that we're uncertain as to just exactly what we're dealing with, and we don't know what the outcomes will be in an individual case. So there's some probability that we'll have a positive effect with a given treatment if we have the right diagnosis. There's also some probability of adverse outcomes and complications that can arise even if we've got the diagnosis right. So I want to take a step back here and say, why do these sort of evaluations at all? As I said, it's motivated by the need to make choices, to actually decide something. You have to do a treatment or not treat, which treatment among a set of treatments, what even broader, what sort of facilities to build, what do we want to invest in order to be able to provide certain types of treatments, and what research to fund, right? That's all choices. If I fund one particular line of research, that takes resources away from another. And we run into this in particular in healthcare, and this is where I would like to pause and ask the question, why? Why?
Finite resources.
Pardon? Yeah.
Finite resources.
Yes. We have to deal with the problem of scarcity. We can't do everything that we might like to do. A way to come at this too is why, I mean, we have finite resources across the board, and we don't typically have, if you're buying a car, you don't typically hire an economist to come do a cost-effectiveness study to say, well, which car should I buy? How do we allocate most of the resources, most of the goods that we value in society?
It would be a capitalistic approach.
Yeah, I mean, in the market, it's a free exchange, okay? So, but healthcare seems to be a little bit different, and here people come at it different ways. I like to pose the question, how many folks think healthcare is a right? Okay, I mean, and among healthcare providers, you find that attitude more common than among the general population, but I'd say usually whatever group that I ask that to, I get a plurality of people. Often with graduate students, I get a large number of people that are uncommitted and unwilling to raise their hand one way or another. But the plurality typically goes, yeah, okay, I'll come down that. Now, is it an unlimited right? Do you have a right to as much health care as you can possibly benefit from? That's, okay, all right, so that sort of sets up okay, so we're not going to, if it's a right, then we're not going to say, okay, well, you can buy what you can afford. Right? If it's a right, then, okay, well, there's some expectation that you'll have access to at least some level of health care. that, it's like we're not going to just leave them bleeding by the side of the road. We're going to pick them up and take them to the ER. We're going to do what we're going to do, and we're not going to check their wallet first. On the other hand, we can't do everything. Once again, we've got scarce resources. We've got a healthcare budget of some sort. How do we allocate that? And if we're not going to say, okay, well, everybody buy what they want, we'll just do it in a market sense, then we have to make choices, okay? So people have to make choices, and we assign folks the authority to do that. Who's going to divvy up the pie in what way? So what things are we going to buy? And what things are we going to say, okay, well, you can buy that if you want. There's a bunch of health services that we do put in the market. Cosmetic surgery is one of those, so okay, yeah, you can do that, but yeah, we're not going to cover it unless it's in circumstances where we go, okay, if someone's had a mastectomy, then we're going to cover reconstructive surgery because that's part of treating the condition. And we're going, okay, well, that's okay. So anyway, we have to make choices in some sort of way, and we're not just doing the efficient thing and allocating through the market. So then we're going to go on and deal with, and so here we're dealing with scarcity. I used to have to emphasize this a lot, right? It was like, scarcity, what, it's like, what is that? Okay, well, it's just in economics, we have limited resources and unlimited wants, is the way economists like to put it. There's a concept that I want to emphasize now that lies under decision-making and making choices, is the concept of opportunity cost. And it's a particular sort of jargon that is useful, I think, a useful concept. An opportunity cost is what you have to give up to get something, right? So you could have stayed in and caught some extra Z's this morning rather than come to this talk, right? So by coming here, you gave up, whatever your next best alternative was, you gave something up. So you can't you're using this time now, you can't use it for something else, okay? When you use resources to do something, then you can't use those resources to do something else, okay? We tend to think of cost in terms of monetary transactions, okay? In my microeconomics course, we got through the first 2/3 of it without we're forbidden to talk about money at all. People think economists are all about money and this sort of stuff. Money's a nice counter, but money is just a weight that we give to value. Well, and not every transfer of money from one person to another represents a cost from a societal perspective, okay? If I take a bunch of money from fairly well-off people and allocate that to provide healthcare resources for poor people, until those resources are consumed, that's just a transfer. If I transfer a bunch of money from this side of the room to this side of the room, the per capita income or wealth in the room didn't change, right? Now, from the point of view of the people that I took the money from, that might represent a cost to them, but so perspective matters. But typically, opportunity cost means we're giving something up. We're using something that's discrete and finite and giving up the opportunity to do something else. So we've got the Samuelson and Nordhaus economics of the study of how societies use scarce resources to produce valuable quantities and distribute them among different people, or you can't always get what you want. Jagger learned in school. He didn't graduate, but he did okay. So there's different flavors of evaluation that we do, and it's nice to be able to distinguish among them. Most people in health use the catch-all term cost effectiveness analysis, right? It sort of trips off the tongue, it's nice. That technically means that I am I'm measuring healthcare outcomes in an objective way, right? In something that's measurable and codifiable. So lives saved is one, Okay, if I have a certain mortality rate and I can do something to reduce that, then I can calculate how many lives are saved, right? If I go, okay, well, these lives have life expectancy, I can go life years gained, okay? Those are typical rubrics. You see those all the time. It doesn't have to be something that momentous. If it's a screening program, a cancer screening program, what does it cost to detect another case, right? If I'm doing a prevention program, what does it cost to get somebody to target in cholesterol, in blood pressure, whatever you want to measure. So I can do cost effectiveness to achieve anything that I can just concretely measure. So we're not going to get into disputes about what we're measuring. You know, it's like, okay, well, yeah, that's a unit. We can all agree on that unit. In cost utility analysis, then we're actually going to try to get at the value of the thing we're measuring. And that gets a little more complicated, a little more subjective. And here you've got the unit is usually something like quality adjusted life years. People have heard that term? Okay. So that's in other places use disability adjusted life years. These are reciprocal concepts. But the basic idea with the quality adjusted life year is if I'm in good health, then that is more valuable to me than being sick, right? If we look at mobility, I would rather be walking around than confined to a wheelchair, right? I'd rather be confined to a wheelchair than not be able to get out of bed, all right? So we can rank order those things, and so what we do is we try to get at what in cost utility analysis, how do you weight those different health states? How do you decide, you know, what's the relative value of health? And you can see how that gets mushy. Disability adjusted life years is just the reverse. It says how much qualities, we try to maximize qualities, maximize well-being. With disability adjusted life years, we're trying to minimize suffering. That's the way I kind of look at it. So we try to maximize qualities or minimize dailies. It's the same either way. With cost-benefit analysis, we push everything another step further and we value everything in money, okay? In healthcare, you tend to see either cost-effectiveness or cost-utility analysis performed. In other areas of public policy, you tend to see cost-benefit analysis, right? So when we did the Exxon Valdez oil spill, you know, okay, well, what was the cost of that to society? We tried to come up with some way of what would people be willing to pay to not have that happen, and then we're going to go after Exxon and say, you know, you're going to compensate society. So when we pass occupational health and safety rules, there has to be an analysis done that says what's the benefits that's produced, right, in dollar terms, and compare that with the cost of that regulation. You know, so if I say, okay, well, everybody's got to wear hard hats on the construction site, right? And that's going to prevent so many deaths, and it's going to cost so much money, right? Well, what is the value of those lives saved? In healthcare, people tend to think that's a tacky sort of question to ask. So we go, okay, well, we're going to bracket that. We're just going to say we're going to save lives and say, what does it cost to save those lives, okay? And we won't put a value on those. You actually have to if you want to make a choice at some point, but we tend to like to sweep that under the table. So the economists are constantly going back and forth, you know, should you really be doing cost-benefit analysis rather than all this? At the end of the day, these are all analogous ways of weighing the relative value of different things and informing choices. So when we're evaluating the effectiveness of things, and here I say effectiveness loosely, we first ask in healthcare, does it work under carefully controlled conditions? In a randomized clinical trial, how does it do? And we refer to that as efficacy, okay? So that's the maximum benefit, net benefit that a program can have. It's delivered to a very select group of people that have signed up for it, and carefully analyzed and usually delivered by people that know the most about it. Then we go, well, what does it work if we now take this out into the world. You take it on the street, and now it's not, Mike Sag doing this, now it's Marcus Welby doing it, so I date myself. But it's, the typical general practice physician with the typical patient that takes his pills, most of the time, well, how does it do then? So that's effectiveness. How does it work in the real world among regular folks? And then once we've established effectiveness, we're up with the question, is it worth it? What does it cost? All right, so we have a new treatment for hepatitis C. Most people are familiar with that. It's a bad disease. If it gets to you, you want to get rid of it. With this treatment, of course, the treatment is like $80,000, something like that. Is it worth it? And it's a legitimate question. There are alternatives that are cheaper, that aren't as nice. Is it worth the incremental? And when we're asking those questions, the perspective that you take matters a lot. Who wins and who loses, who pays. So different points of view. In the gold standard, which is, there's a text called Cost Effectiveness in Health and Medics, and that is the U.S. Public Health Service Consensus Panel statement on how we should do all this. And it's called the gold standard because Marcia Gold edited the book. And they say, well, we want to do all these analysis from society's point of view. So we want to total up all the benefits that accrue to anyone and all the costs that are impinged on anyone, and do the analysis from that point of view, right? And that can be useful because that allows me to compare measles vaccine with bypass surgery, right? Because I'm looking at everything. Okay, so I can do that. And the problem is very few people actually make decisions from society's viewpoint. People tend to take decisions from their own point of view, which is often more limited than total benevolence and knowingness and everything. It might be a government agency point of view. And I like to beat up on the National Health Service because of the National Center for Clinical Excellence, National Institute for Clinical Excellence, which is nice, and so there's a nice way of doing things, and they do cost-benefit analysis. And if it costs more than £3,000 per quality-adjusted life year, then you're not going to get it. So they're rather firm on that. There's some exceptions, but they're rather firm on that. But basically, they have a different, the National Health Services has a different perspective than some total societal point of view. The classic example was a new chemotherapy drug that had about the same ultimate outcomes, but it got people out of the hospital faster. So you could deliver a course of treatment more quickly, get them out of the hospital. That's fine. From the National Health Service point of view, we've got a queue of people waiting for that bed. That doesn't save us anything. So it's not worth the extra money. Oh, okay. Oh. Might be worth it from some point of view. You have an insurance company's perspective. People beat up on insurance companies for, well, all they care about is the bottom line. Okay? I'll offer you insurance. I'll do health insurance that costs only $5 a year. The problem is it's 100% copay. In other words, I'm not covering anything. So nobody's going to buy that from me. So the insurance company does care about the product that they deliver, but they also care about the cost of it. So they have to make those sort of trade-offs. What cost does the insurance company care about is what they have to shell out, right? What cost the providers is what does it cost me to deliver this service? If I'm a hospital executive, I have to pay the nurses, I have to pay the staff, I have to keep the facilities maintained, all this. What does it cost me to provide services to people? And they care about what they get paid, but does the insurance company care about what it costs UAB to do bypass surgery? Not really. They care about what they have to pay UAB. So when they get into those negotiations, UAB will come back and say, well, it cost us all this money to do this. Right? That's nice. That's an argument you can make, so. But here's the bottom line. Who's got the market power? Who can set the price? Patients and families have another point of view. Do I care what it costs UAB to do my bypass surgery? Not really. I care what I have to pay out of pocket, right? I care about the time that I have to put into it. And here's where informal caregiving comes in. If I get people out of the hospital sooner and sicker, such that folks have to stay home with them and help them with their aftercare, that imposes a cost on families that, frankly, UAB doesn't care. We're really nice, we really do care, but we don't care enough to change our behavior. But anyway, so I mean, it's basically point of view matters. And when you're doing some sort of analysis, it is not wrong to do an analysis with a particular point of view in mind if you want to influence someone's decision making. So we've got uncertainty, we've got competing objectives, then we have this method called decision analysis, which tries to incorporate all this. And what we want to do, the objective of a decision analysis approach to decision making is to maximize expected values or minimize expected costs. Okay? Now, expected value is another one of these concepts. It's the weighted average of all the outcomes. Okay? So what's the probability that something will happen times what is the measure that we're going to put on that? What's the likelihood that I save a life, a 10% probability, times 10 years of life, right? Well, I saved a life year. That's the expected value, okay? There are other ways we could approach problems rather than saying, well, let's make things the best they can be on average. What's another approach I might take?
You want to avoid bad things?
Yes. I might want to, instead of saying on average this is going to work out, to minimize the likelihood of just total bad things. It's like, okay, yes, all right, I might extend my life here on this, but, at the risk of I'm going to, if I don't extend my life, if I don't get the life here, then I die tomorrow, right? Maybe I'd rather, okay, well, maybe the average, doesn't work for everybody the same way. Maybe on average, all the safety features were exactly right, figured out, but just, well, the dice rolled wrong and the oil came out of the middle of the Gulf and it's a big mess now. So we might have, rather than, doing the cost-benefit analysis that said we're going to weigh the benefits and harms and everything like that, we might have said we don't want to get in that sort of situation, okay? So you don't always see cost-effectiveness analysis, decision analysis is not always the right answer to the question. And it's important to know what are the assumptions we're doing on a population basis where we're trying to make decisions for lots and lots of people over time. It's arguably a reasonable approach to take. But you can deal with, it's important to know there are other ways to do this. There are ways you can tweak it to do exactly that. Let's, instead of maximizing total, there's the Rawlsian approach where you maximize the least person. You put resources to the people with the greatest need, even though they may not be the people that can benefit the most. The decision framework is based on trees. Simply build these trees. This is a very simple one here. You got a problem, and a problem is different than a circumstance. I have a problem if there's something I can do about it. If there's something I don't like and there's something I can do about it, then that's a problem. If it's something I don't like and there's nothing I can do about it, that's just a situation, okay? So I've got a problem, and so I have a choice to make. I can do one thing or another thing, and if I choose one way or another, there's some probability that a good thing will happen and some probability that a bad thing will happen, and there's some metric that I'm going to use to code up, how many goodness units it's going to be, life saved, life years, cholesterol targets met, whatever. Bad things, hospitalization for MI, you know, whatever I want to count. And I put those on the payoffs. The deal is all the payoffs have to be in the same units. Okay? Probabilities all have to sum to 1. So here's a simple one. We can play this game. You have a choice. I'll toss a coin. If it comes up heads, I'll give you $1. If it comes up tails, you give me $1. Or you can choose not to play. The expected value is the same in both circumstances. It's interesting that people are not indifferent, right? How many people play this game? It's a better odds than you're going to get anywhere that plays odds. This is a fair bet. You know, people go all the time and play really, really long odds bets. You know, this is the lottery or whatever. You know, Vegas, Biloxi, I guess I should say. I can get graduate students to say, 1 or 2 graduate students will say, yeah, I'll play that game with you. I'll play for a fair bet. And I'll say, okay, well, let's do the same game, except let's make it $1,000. Still want to play it? So do you feel less likely to play if we up that? You know, it's the same expected value. So, but we have, you know, we have loss aversion. We have all kind of interesting psychology goes into this. But that's also why decision analysis is built on some assumptions that don't always hold. So we can build in risk aversion to the models, and that's fine. There's an old expected value. Here's the question. You have one of these suitcases that has money in it, right? This is the distribution of suitcases that is left. You don't know which one you've got. You might be holding one that has $5 in it, or you might be holding one that has $500,000. The expected value is the sum of all these times the probability of each, okay? So it's the sum of those divided by 5. So the expected value is 107,000, 170,000, a little more. Now I'm offering you a little shy of 150,000 to just walk away. Here. Now, if I'm on the game show, I'm taking the money. Having fun. That's, you know, 150,000, you know, versus a chance that I might have more. Okay. Here's a healthcare example. Appendicitis. We think somebody's got appendicitis. Pretty sure they got appendicitis. How much do we think they have appendicitis is an interesting question there. And the choice is, do we do surgery or not? If we do surgery, then they either die from the operation or survive. If we don't do surgery, and if they don't have appendicitis, then they're fine. Okay, they'll get over it. If we don't do surgery and they have appendicitis, then there's some chance that they'll die from the appendicitis. This is not the decision that we typically face currently, but back in the day, surgery was the right decision even before antibiotics, if you really thought they had appendicitis. Here's the real solution. Here's the real sort of question. We think they've got abdominal pain. That's what we know they've got. And we're thinking it might be appendicitis. We can do surgery or not. Or we can gather some more information. So we can do some testing and improve our probability that it's appendicitis. We still may or may not be correct, right? But we can get much better. So today we can get pretty good at that. I think we can narrow that down. The uncertainty left is, so you always have another choice besides do something or do nothing, or between do this and do that, which is gather more information. The gathering more information can have costs associated with that. And what's the quality of the information matters. So, so measuring costs, what do we do? What costs do we count? And so if we're evaluating a treatment, obviously the cost of that treatment matters. If I'm looking at warfarin, it's not just the cost of the drug, it's the cost of regularly doing coagulation studies, right? All this sort of stuff. And related costs, right? If I'm using warfarin to prevent a stroke, then, all right, the cost that I save from not having to treat that stroke, that weighs against the cost of the drug and all the testing and all that. If, though, there's a chance that they're going to develop a hemorrhage, then the cost of treating that have to figure in. So all those related costs, okay? The interesting thing comes into, what about unrelated costs? I prevented your stroke, you didn't die, and so you got cancer. Do those costs count? That's the philosophical question, not a right answer. But so you can push this, all of these things, you can push them so far that it gets a little silly. But to a lot of people, that's absolutely, and it really does matter. It changes the way you weigh things. You know, do I consider those other costs? Estimating healthcare costs from a patient perspective. This is one of my hobby horses. This doesn't get done very much. With important exceptions, the costs are relatively small relative to the direct healthcare costs, right? People pay, if you look at what people pay out of pocket, it's usually a fraction of what the cost of the services are, right? So if you're looking at, if you're trying to take a big picture, more attention gets paid to what the government pays or what Blue Cross Blue Shield pays or this sort of stuff or what it costs UAB. I do those sort of things. The real reason that you don't see these costs included very much, I think, is because they're expensive to collect. I can do a real quick and dirty cost analysis of some procedure using Medicare claims data, and maybe not as fast as some people would like, but we can do that and fairly economically. But if I want to know what's the cost to people, then I'm going to have to go out and collect that data in some sort of way. It's not laying around in some database. So I think that gets to it a lot. Why they're important, there are real costs. One of the areas that we're interested in is long-term care. And if you look at informal care in that setting, however you go about valuing it, the cost of informal care and long-term care is probably 5 or 6 times as much as the entire Medicaid budget, which pays for most of the nursing home sort of care. But all the costs that people, all the care that people get from spouses and friends and children in order to stay in their home, that doesn't get compensated. If you value that time, it's an incredible amount of cost. So the real cost there, and patient costs also affect their behavior. If I have to pay more out of pocket, I'm less likely to be adherent, less likely to use preventive services, this sort of thing. And then patient behaviors come around and affect direct health care costs. So, you know, if I'm not doing the stuff that I should do to minimize cost to society, then well, that actually turns around and imposes a burden on society. So these are important things to do. That's my little hobby horse. I like the patient perspective. Let's do that. Let's cost from a patient perspective, pecuniary, out of pocket, coinsurance, deductibles, travel time, lost wages, non-pecuniary, waiting time, unpaid caregiver time, and some people put stress and distress and things people do to cope with distress as part of the cost. So, I'm not going to spend a lot more time on this hobby horse. This is what you pay for various things if you're a Medicare beneficiary. And collecting data on that. Other pecuniary costs, let's see. I want to kind of get through this. So I've sort of said what I have. Economics of caregiving. Okay, now I want to get to measuring effectiveness again. I can look at clinical endpoints. Blood sugar, hemoglobin A1C, cholesterol levels. So I can look at what does it cost to get those things where I would like them to be. Okay, perfectly legitimate way to control, to compare different statin therapies or different lipid-lowering therapies now. We've got other things in the pipeline, and say, okay, we have the cholesterol target. What does it cost to get there with atorvastatin versus some rosuvastatin, which is still under patent, right? So big cost differential. There's a different differential effectiveness, and so you go, okay, you can weigh those things, and so that allows me to compare statin therapies, but it doesn't allow me to compare statin therapies with something else, right? So then I have to go to outcomes like infections avoided, survival, that sort of thing, cases detected, that is more larger, measurable thing. And then if I want to get at preferences, then I'll talk about utility. And I want to talk about how we approach this as an important concept that nevertheless I think has some problems in current methodology. So what do we value in general? We value stuff we like. What do we value about healthcare? It's not something that we go out and consume for its own sake. I'm not saving up for my MRI that I'm just dying to get. You know, I really want. I'd like a cardiac cath. I just can't afford it. You know, it's like that's not what it is. It's like we value healthcare for its effect on our health. And we value health because health allows us to enjoy life, right? So all the other things that we enjoy, if we don't have sufficient health, then we won't enjoy it. The question is, how do we measure the value of health? And here's how we do it in health economics, okay? We imagine a scale from 0 to 1, where 0 is equivalent to being dead, and 1 is equivalent to being well. Okay? And we're going to rank health states on that scale. We're going to give every health state, you know, it's like if I'm on hemodialysis, that's often close to about a 0.5. They really don't, people on hemodialysis really are not happy with the way things are going. You know, it's like so that's why one reason that even though it's quite expensive, kidney transplants are very cost effective because they save a bunch of money. Dialysis is expensive and miserable. So this, though, gives rise to a couple of interesting questions. Are their health states worse than death? Which is another philosophical question, right? There are folks that firmly believe that no, because once you're dead, you can't have anything. You know, it's like, there are other folks, it's like, I'm an old burnout ICU nurse, right? And I was practicing before Quinlan and Cruzan decisions. Who knows those?
Is that the definition of brain death?
This is, it even goes beyond that. I can refuse treatment. When I was practicing, failure to intubate somebody was manslaughter, regardless of what they wanted, right? But then somebody goes, you know, like, you can't do that. It's like, I mean, we had in the day, you know, people begging us not to do stuff, right? In the ICU, and we started, you know, it's like, we had the slow code, you know, code 500, please get the crash truck. And, you know, you have to go through the motion. You have to document that you did the code. Otherwise, you know, okay, things changed over time, and I think for the better. But there were folks in the ICU that said, yeah, my health state is worse than death. Leave me alone. There are, you know, people in other really bad states of misery that would go. We have a couple of states that actually recognize that de jure, you know, and allow assisted suicide. And say, yes, okay. So that's a recognition. Okay, well, it can't be. All right. So you can quibble about that, but we can go, okay, death's pretty bad. So we can give that a 0 and say if all you have to do is allow negative numbers, and you can have states worse than that, so it's okay. What about states better than well?
Depends how you define well.
Yes, it does. So there's the World Health definition, which is essentially all your Maslow's hierarchy of needs have been met. You're loved and respected, self-actualized, you know, essentially nirvana, you know, and anything less than that is not well. So that I go with one that I like this definition. I can't attribute it because I don't know if I made it up or stole it. But I use it. It's like I'm well if I don't have any attention on my health. If it's not bothering me, you know, then I'm fine. Right? And that lets me be well when I was much younger and ran marathons in Hawaii all the time. You know, it's like a blister on my foot would be less than well, right? Now, if I get up and I'm not too achy, then I'm doing fine. You know, so okay, all right, it's not going to be a bad day. The knees are working. So I mean, basically, so it's, either one of those is subjective. It's like where you put that. Now, also, I'm a child of the 60s, better than well. Some people think, you know. But anyway, you can see how that gets a little problematic. So that's what we do. We can bracket that. I think it's important to distinguish the relative value of health states. It's a really important question. It doesn't mean that we have a good way of doing it. So that's my little thing on that. So now we've got cost effectiveness, which is just another tweak on decision analysis. So now I'm measuring two quantities. One is the cost, and the other is the effectiveness, right? And so for simplicity's sake, we're going to look at cost in dollars and effectiveness in life years. I could treat somebody. I don't know what that does.
More than 10 minutes.
Oh, is it going to do something bad? Is that the one?
That's fine, yeah. No, that's 2 minutes. That one. And that one.
Oh, thank you. So anyway, so this is the decision tree when I'm doing cost effectiveness analysis. And we typically get a cost effectiveness ratio is the result. And that's what does it cost to produce a unit of health. The units are either natural units in cost effectiveness or utilities in cost utility analysis. The perspective you take determines the cost. Now, the right way to do this, okay, so cost effectiveness ratios then fall somewhere in here, all right? So if you've got the horizontal line is the effectiveness measure, how much help you get, and the vertical line is cost. So think of it as where they cross, that's the origin, that's zero, no effectiveness, no cost. If you go down, you're saving money. If you go up, you're costing money. If you go left, you're making people worse off, and if you go right, you're making them better off, right? Now, what if I fall up here, and I've found something, I've done my analysis, and I found, oh, this arthroscopic surgery is very costly and makes people worse off. My decision is easy then. Most people will agree with that. If that's truly, if you believe the results of the trial, then you'll go, okay, well, we'll just stop doing that. We'll stop paying for it, and people will be better off, and so fine, okay? What if I find out it saves a bunch of money to give people aspirin after they've had an MI? Dirt cheap, saves a ton of money, makes people live longer. Well, let's just do it. You know, it's like I don't have to then worry about it, sweat that. Oh God, should I give aspirin? No, don't worry about it. you know. However, if it costs something in order to get something, then I have a question about is it worth it, you know? And that perspective matters on that, and circumstances matter on that. What's my budget constraint, right? It's very different here in the United States than in some place that has a healthcare budget equivalent to, you know, $300 a year. Another thing to consider when you're looking at these ratios gets back to what's called what I talked about as opportunity cost. There's a common mistake to simply compare the cost and effectiveness of something with nothing and do that for a whole bunch of different alternatives. But if I have more than one choice, more than one treatment choice, then if I do one thing, that means I'm not doing another thing. So it's not, the right comparison is not nothing. It's what was the next best alternative. If doing nothing is an alternative, so here's incremental versus average. So I've got treatment with a statin for a 30-year-old male with a certain profile. I can treat him with 20 milligrams or 40 milligrams, right? If I treat him with 20 milligrams, then the average cost per life year gained is about $40,000. So it costs $16,000. I get 0.4 years of life, so about $40,000. 40 milligrams at $27,000 buys me 0.6 years of life. So it looks like, and some people will calculate a ratio. You see this in the literature, not infrequently, but they'll report that number, the $45,000. If my threshold, my budget constraint says if it costs more than $50,000 per life year, then it's not a good deal. Says, oh, well, this 40 milligrams makes sense, okay? But if I look at what does it cost to treat somebody with 40 milligrams versus 20 milligrams, which is the real choice, then I have to say, well, how much more do I have to pay to double the dose, and how much more benefit do I get out of that? And now I'm all of a sudden above my $50,000 threshold. Okay? Now you often hear this 30 to 50,000 or 25 to 50,000 threshold, which is completely arbitrary and hasn't changed for 30 years. So really our willingness to pay is probably closer to the value of a NICU. Neonatal intensive care unit generally produces costs something like $200,000 per quality adjusted life year produced, because it's really expensive, and a lot of the outcomes after NICU aren't the greatest quality of life anyway. So, but that's something we do all the time. We're not shutting down, we're not going to go, oh, well, we should shut down all the NICUs because they cost so much. It's like, no, that's sort of about where our threshold really is, I would say. So I want to step through one that's an ancient example. This is prophylaxis for opportunistic infections before heart and all this kind of stuff. So I like to use old examples because nobody quibbles with them anymore. It's like, oh, no, we wouldn't do this or that. You know, it's like, yeah, we haven't done this for years, so don't worry about it. But so I've got just a bunch of different drug combinations that I can use. So I can do something really cheap and prevent some infections and do that. So there, and I just number these things and don't worry about it. It turns out that they're numbered now in order of increasing expense. You can order them in terms of increasing expense or in terms of increasing effectiveness. It doesn't matter which way you order them. You're going to do the same sort of analysis. But now I'm not worrying about which drugs they are. I'm saying, you know, how much does it cost to do what? And so I order them this way, and I see some interesting things that show up better graphically. So here's the cost and effectiveness graphed out. And if you look at option numbers 4, 6, and 8, what stands out about those? So let me see if I can do this.
Less effective and cheaper alternatives.
Yes. So those are said to be dominated alternatives, right? It costs more to do that, and I get less health improvement, and, oh, that's right, this doesn't work. Okay, so I can't highlight things. I would go over there and point to it. So 6 is the most striking one. It costs considerably more. It's more than almost $7,500 more than the next best alternative, and it produces worse or less health. So we would never do that. And you start to see that here. Now you just look at the numbers and you go, okay, anytime that the costs go up and the effectiveness goes down, just take that out. Just take that off the table. Okay? So those are said to be dominated options. And now we graph it without the dominated options, and we're going, okay, well, this looks more reasonable. To buy more health costs more money. 7 is a little odd here. 7 costs more and is more effective than 5, but it just looks a little peculiar. It's we call that concave. The curve is concave. And if you look at the cost effectiveness ratios, then we're going along 1,200, 2,400, 4,700, 25,000, 5,000. What that says is I can always beat 7 by some combination of 5 and 9. Okay? So if I go first come, first serve, I'm going to treat people with 9 until until budget crunch time comes, and then everybody after that gets 5, or you do random numbers or something like that. This is said to be weakly dominated, right? Now there's a political constraint. If I can't treat if I can't do this where, okay, well, I'm going to treat the first come, first serve, with the good stuff, and then after that runs out, you're going to get the not so good stuff, There may be constraints that say, no, you have to leave 7 on the table. But from a purely economic point of view, you would not do 7. You'd do some combination of the others, and you would get more bang for the buck. So then we redo this, and what we have nicely now is for me to buy more health costs more money for every additional unit of health that I want to buy. Some people stop me and go, well, why does number 1, which is do nothing, cost $40,000?
They get infection.
Yeah, they get infections. We're going to treat them. We're not going to do nothing. If doing nothing is really an option, best treatment for MI is massive doses of morphine. But it's very cost effective. But if you don't value effects at all. But anyway, graphically, so now we've got this. And we can say that was per quality adjusted life months, because it was, we're trying to measure something that's hard to measure. We translate that to dollars per quality, which is a more common metric. And this says, okay, that's what it costs to buy qualities with each of these strategies. Now, what's the right choice? That's where the economist leaves the room and said, no, I just identified the trade-offs. So you have to decide what your budget constraint is, right? So that's going to come from here we're trying to decide which thing to do. If we can afford to do $150,000 per quality, if I can afford that, and I've used up, that's my budget constraint, then I can go for it. I can use it all. If it's somewhat less than that, then not. So at the end of the day, we're left with another interesting puzzle, which is how do we deal with uncertainty here? Typically here at an academic institution, we know how to deal with uncertainty. We do hypothesis testing. What's the p-value? So I've got a new treatment, life-saving. We think it's life-saving. These people live a year longer, but the p-value is 0.08. Darn it. I often get asked, I work through a difficult decision problem and say, this is marginally better than the other. And the student says, well, but is it significant? Is the difference significant? And I go, oh, you think we're doing science? We have to make a choice, right? I'm going to use the best evidence that I can. What I do is a sensitivity analysis that varies things in the model that I know are uncertain and say, does it matter? You know, what if the probability is what if the probability of this is not really 0.6, but 0.62, okay? If that matters, okay, then I might want to invest some money into doing some research and nailing down that probability. If it doesn't matter, then it doesn't matter. I can look at different scenarios, do probabilistic sensitivity analysis. I can get really complicated. What I don't do is throw out the information and say, until you can come up, I'm not the FDA. I don't say, you know, it's like, well, you got to meet certain significances. I'm going to go, here's what I would recommend. I think it's a crummy recommendation because there's so much uncertainty. And then I do a value of information analysis of what would it be worth to resolve that uncertainty? And then that goes to inform the research resource allocation problem. So sensitivity analysis, typically you do a one-way analysis where you've got these models with these probabilities and costs and effectiveness measures, and they all have uncertainty attached to them. You vary them one at a time, holding everything else constant, and say which ones are the ones that really rock the boat. Which ones are the ones that, if it's at one end of the uncertainty of the other, it's going to change my recommendation. Okay? Those are the things that, okay, those are the uncertainties. That's where the research priorities should be. Okay? I can do a scenario analysis where I set every value to the extreme in favor of one treatment and every value to the opposite range of uncertainty. And if my result is the same, that's a robust analysis. It says, okay, under every circumstance in the world that's realistic, I'm still going to go this way, right? We're still going to give aspirin to people. I don't know exactly what the cost effectiveness or the cost savings, what the ratio would be for aspirin versus not giving aspirin to people that have an MI, but I don't need to. It's like all the twiggling around that I can do with that model still says, oh, saves lives, saves money and lives, okay? There are other things we're more on the fence about. But if you come up with the same answer under both scenarios, then that's a robust finding. Probabilistic sensitivity analysis, what I've done is I've done a bunch of simulations, right? I've said, let's vary all the probabilities together, right? And put in joint distributions, everything like that. But I've varied everything that I can vary, and I can produce a scatter plot like this. This is an interesting one that says, okay, the highest probability is that this is a dominant strategy, right? It saves money and makes people better off, right? It's almost certainly cost effective if this is my decision line. That's the threshold, right? So I'm going, okay, well, that's really cool. I can also plot what's called cost effectiveness acceptability curve. It says, what are you willing to pay for a unit of health? I'm also uncertain about what my willingness to pay is, right? What's the likelihood that at a given willingness to pay that I would consider this to be cost effective? And here we're actually slipping over into doing nothing but cost benefit analysis. Don't pay any attention to the man behind the curtain. But there are some interesting things you can get with these. What does it mean that there's a 25% chance that I would consider this cost effective if I don't value health at all? Means that there's a 25% chance it saves money. Okay, so that's the only reason that I would think it was cost effective if I didn't value health, right? Now, you can go to the other extreme. There's a 75% chance, no matter how much I'm willing to pay, that it's not cost effective. Or a 25% chance, regardless of how much I'm willing to pay, that it's not cost effective. And that means there's a 25% chance it doesn't work. So, you know, the effectiveness is maybe, you know, so it can go either way. So, so these things can fall out. This something like this says, I'm really uncertain. I did this analysis and I really don't know what to say. If you get a curve that looks like that. I've got some like that. I've got one where all the scatter plots, and this was screening for esophageal varices using PillCam versus endoscopy, right? And it was a lovely cluster all around the origin. And just saying, I can't tell which is better. It's like one's got some problems with sensitivity and specificity. The other has some complications you probably like to avoid. And we couldn't figure out. Basically, the idea is you could do the largest trial in the world, screening everybody, and you still wouldn't know which was better. So, anyway, value of information analysis, and this has evolved over the time that I've been teaching it. So it's been fascinating to be in this field. It started out of, for a lot of the 90s, people tried to worry about how do we put confidence intervals on these cost-effectiveness ratios, right? How do we do that? Because it's really tricky mathematically, and interpreting negative cost-effectiveness ratios is a crazy exercise. So we went to doing sensitivity analysis more than hypothesis testing sort of exercises. And what we do is we say, here's the best information I have now. This is what I think you should do based on this current state of knowledge. So I did the lit review, and I still don't know whether colonoscopy or Flex 6 versus with fecal occult blood testing annually, which is the better strategy for screening for colorectal cancer. I had to come down on it today. I'd say go colonoscopy, but that's the problem is a lot of studies don't even get into, well, what's the uptake? And so it's like if you do it, then probably colonoscopy is the better, but it's iffy. So anyway, I don't know on that one, but I'm going to say, okay, this is the best thing to do. But this, what if I'm wrong? So value of information analysis goes, what's the value of obtaining more data? So it's like, here's my recommendation. What if I'm wrong? What's the likely impact on health and costs and all that? And I can estimate that. And then I can decide that doing that analysis will inform me also what are the parameters of the trial that needs to be run in order to resolve the uncertainty, and what would it cost? So then I can compare the cost, the value of the information with the cost of obtaining. You just pause a little bit on that. David Meltzer at Chicago did a nice one. There was a trial of one of the new antipsychotics for schizophrenia, and they found a modest but not significant improvement in quality of life associated with the new generation drug. So it was not approved. So Meltzer went and did a value of information analysis and said, okay, here's something that affects people over a very long period of time, and it's a lot of people. So if this result was real, what would it be worth it to know that? And he said, oh, well, it would be worth actually running a trial with 40,000 people in each arm, if that's what it took to resolve that uncertainty. Because even though it was a small improvement, it was affected a lot of people for a very long time. So I've actually gotten stuff funded by saying, I'm going to do this observational study, right? And at the end of the day, I'm going to have a recommendation. I'm going to do a cost-effectiveness analysis, and it won't be definitive, but it will tell you what's the value of information of doing that. And I've sold stuff that way that I was unable to sell anybody. Oh, you're just going to do an observational study. I'm not going to believe that. So you don't have to believe it. What I can do is then put the parameters of what, what's the research priority going forward after that. So how is it used? Drug approval in other countries. So FDA doesn't look at cost effectiveness, and very few people admit to doing cost effectiveness analysis even in the industry. It's starting to percolate up a little bit, right? CMS actually went to the point with erythropoietin for people on dialysis where they say, we'll pay for it up to a point. They used to pay for it to get people up to normal hematocrit, right? Healthy hematocrit. Now they'll only pay to get people to avoid a transfusion, right? Had a huge effect on Amgen. Conflict of interest. I get a lot of money from Amgen for research, but that was like, okay, they're starting to actually consider costs. It was just shocking. It does get help. It does get help in prioritizing programs. If we're allocating public health dollars, then we do look at bang for the buck, and we say, so it's not like we're not going to do mental health for kids, or we're also not going to get rid of juvenile court and all that kind of stuff. But we're going to say, okay, where should we put our priorities? Where should we put more resources? Yes.
On that line, a big part of my clinical practice is doing liver transplant, and the priority is just based upon how sick people are to get allocated organs and whatnot. But as things have changed, they're more sick to get the organs and whatnot. And most patients are disabled and on disability, Medicaid, and get transplanted, and probably never come off it. And I've always thought, like, hey, if I'm insured, probably the cheapest thing is if that person dies, not to do a transplant. That's very effective. They live on disability for a long time, but now I've got to pay for expensive immunosuppression and whatnot. And I wonder where, and one of the disappointments in the field is that the percentage of people that kind of come in from home that are working, that get transplant to get better and go back to work is becoming, fewer and fewer and fewer and fewer because of the system. And I was just wondering, in a scenario like that, is there any existing guidelines to how you value or measure or prioritize somebody who works versus somebody who doesn't work, or is that just politically no land?
There's where political constraints really do come in, and where we tend to push, because you'd probably get better results in terms of health outcomes by transplanting healthier people. If they needed a liver, you probably want to give it to somebody that was in better health than somebody that was in worse health.
There's a sweet spot, that kind of right in the middle.
Yes, but we don't do that, right? We give it to the people that are most seriously ill, right? Isn't that pretty much?
That's correct.
So yeah, that's not economically efficient. It might be equitable from a standpoint of, well, they need the liver, they need it. It's like, well, he needs it more than him. But yeah, I mean, it's.
But are there models where you can do that, where you can incorporate, somebody that?
Believe me, the nice way of doing things in the past, the British way, they didn't do dialysis over 50. This is before there were any transplants.
No. So I get that, but I'm just wondering, like, my question is, are there models or precedents to calculate, some of these cost effectiveness?
It certainly can be done. It certainly can be done in saying, here's what would be the economic impact of changing the way we allocate organs. A lot more is being done in terms of, well, can we incentivize people to be donors? And what's the cost effectiveness of that? And with kidneys, it's incredible.
Yeah. Kidney, like break-even point 17 months for dialysis versus transplant. I mean, yes. Work that out pretty well. But in all the other solid organs, there isn't a dialysis machine for them. So the cheapest thing is death. Mm-hmm. It's an interesting, but I think that the field is kind of changing more and more as healthcare has gotten better with managing end organ failure. That we kind of keep people trucking along, and again, that gets back to your well versus not well. They're kind of on that 0.5 or less, but they're not at 0. Yes. And I just kind of wonder. It'd be interesting, and that's something I've thought about a lot. Like, well, how do you quantify that? How do you met, for folks not to figure out if somebody's working or not after transplant? Because there's some people that are on disability would get better and could go back to working. Although I think that's probably a rare event. I don't know if those are measurable things or whatnot. But I think that would, information like that might resonate a lot with the community.
I'm in favor of doing analysis that are informative. Sometimes you want to go, okay, well, is this going to change anything? It's like, okay, so I say, okay, if I redo it, then I'll get this much more. I'll decrease the cost per quality if I reallocate organs differently, right? Okay, and I might get, well, thank you for that analysis. How do you get a publication out of it? Is UNOS going to do anything? I don't know. It's an interesting one because I was at RAND when they were considering, there was a push for RAND to sort of take over that and do it rationally and all that. And they looked at it and looked at all the politics of it and said, no, we're not going to do that. We're not even going to bid for it. So, I mean, the other thing is, centers, where do the organs go? Does it go to some place that does 2 or 3 transplants a year? Or, that sort of thing, it's like, oh, why are you doing this? Why shouldn't it be, oh. So anyway, we use this stuff for drug approval for placement of care, determining some benefits. Where on the tier are you going to put this drug, right? It's a really good drug and it's going to save me a bunch of money and other healthcare costs. Then I might want to make the copay pretty low. But if it's just slightly better, if it's it's ezetimibe added to statins, then okay, yeah, it's good, but it's cost a lot, so you're going to pay for it. You can get it. Prioritizing programs, treatment decisions, not very much here. I can go to a physician and say, this isn't terribly cost effective what you're up to. You're going, well, thank you for that information. Summing up, I think we have a way that we can compare treatment options for conditions pretty well, okay? That we can definitely compare apples and apples very nicely and say, okay, well, is this apple really that much better than this apple? I think we can allow comparisons among treatments for different conditions with less certainty, but I can say, what's healthcare compared with prevention, and it doesn't always fall down on prevention. It's not always the best. Sometimes, well, let's see what happens. It's a guide to decision makers, but there's still the question of what's worthwhile that has to be made, and is it one size fits all? Maybe not. Maybe for rare, very expensive things, we can afford to do that. So cost effectiveness may not drive everything. It rests on a set of assumptions that don't reflect everything we might value. So it's like there's nothing in my models that reflects on equity at all. So cost effectiveness, the equity thing, it's like I kid around with people. Somebody goes, well, that doesn't seem very fair. I'm going, well, this fairness thing doesn't resonate in my business. But I think we do care about equity. It's not everything, but should we ignore it? Should we ignore personal agency? There are a whole bunch of things that we might consider. It's like that's where I've got to. I'm happy to discuss. Yes.
So when you submit a clinical trial grant, are they expecting any kind of cost-effectiveness analysis? It turns out to be a very interesting question. Early, when I came here, it was all the rage. We're going to add cost effectiveness onto these trials. And most of my job was to sit down and explain why they did not want to do that. Typically your cost distribution has a lot more variance than whatever health outcome you're trying to measure. And so I would go, okay, you're going to do this trial with 40 people in each arm. No, I don't think we're going to do any cost estimation off of that. Maybe if you triple it, and you're going, okay, well, we can afford 40, can't afford, 120 in each arm, going. It was even worse. He was thinking, we just did this trial, now we'd like to add cause effectiveness to it. Okay, all right. We can just go to the literature. You know, I'm used to doing models and simulations and that kind of stuff. You don't have to. If you've got a really big trial and if you've got a really big trial that you're doing, and it seems reasonable and real good value added, but measuring cost, it's like if we get folks know the EDGE study, the big pragmatic trial for taking a drug holiday with bisphosphonates that Ken Sack's putting together. So with that one, it'd be easy because when the follow-up is using Medicare claims data to determine fracture outcomes for people on or off, you know, big pragmatic trial. And the main, so I'm using claims data to follow people to look at fractures. I can look at the cost. So adding cost effectiveness to that is rather trivial added cost. But if I'm doing a big trial and I've got people with big mix of different payers and everything like that, multi-center trial with some people on Medicaid, some people on Medicare, some people with private insurance, where am I going to get the cost from? I'm going to have to do something, you know. So the data collection can also get pretty expensive. So there's different ways to go about it, but it's like, yeah, I'd say that it's value added, but it may not be cost effective to add to put a cost effectiveness analysis on the trial. Well, thanks for playing. That's all I had for today.
Very good.
Thank you.
That's good. What do you think about what I was talking about there? Is that a possibility? Can we do something like that? What else fields do we need? I'm trying to think like,
So, what we look at hypothetically, and this is almost certainly not what we look at, is what if I give an organ to somebody? So I've got somebody that's at death's door and somebody that's just at the sweet spot. Well, yeah, he should get a liver. He's not at death's door.
let me see, if you're really sick, the wait time's very, very short. If you're not very sick, the wait